Welcome back, everybody, to Through Help and Back. Through Help and Back is a podcast focused on mental health and addiction issues, but unlike some of the other podcasts that are focused on this in a more problem-focused manner, what Through Help and Back endeavors to do is to bring a positive spin, to foster some hope, bring stories of hope and success to our viewers and our listeners. As most of you know, because you found us, Through Help and Back can be found on all major streaming platforms. And if you want the pleasure of the video and seeing myself and handsome Ian and my lovely guest, you'd go to YouTube and see us on the video production there. So you can also reach out to Through Help and Back at any time. A couple episodes ago, we did a really nice question and answer period with some of our viewers' questions. Ian will yell at me if I screw this up, but you can reach us at helpandback@gmail.com. I'm getting a thumbs up, so I feel good about myself. Helpandback@gmail.com. You can give us topics. You can give us ideas. If you're a guest, somebody you think would be a great guest, you want to refer to us, you can reach out to us there. Or if you just want to talk to Ian, that's the best way to reach him. So before we dive in, we've got a great guest for today, as we always do. But before we dive in, I definitely want to recognize our sponsors. Through Help and Back is fully sponsored by Anew Behavioral Health. Anew Behavioral Health, if you're in Ohio or you're in New Hampshire, you probably already know, is an outpatient mental health and addiction provider. We kind of have it all. We have psychiatrists, we have nurses, we have great therapists, we have case managers. I'm pretty deep into my career at this point. Anew Behavioral Health has really become, the agency that I wish that I had worked for or could have referred to for my entire career. So if you or someone you love is struggling with issues related to mental health or addiction, or just a sense that life could be better and you want some guidance and some help along that path, you can reach out. You can get Anew Behavioral Health at ANEWBH.com. Check out our website. You can also always email helpnow@ANEWBH.com. And somebody from our guests team will actually be able to help you out and reach out and take those emails. We've got Cathy Heid with us today. So Cathy is the director of intake and client access for Anew Behavioral Health. So you probably get a lot of those Help Now emails, and
I get them all.
So we appreciate that. How are you and your team been doing with that? You guys are getting like crazy busy with the intakes and the referrals, right? It's been pretty nuts.
It's not surprising, but it's a lot. I mean, there's a lot of people that are reaching out for help through many different ways, including Help Now. That's just one of the ways that we hear from these people that need our help.
Gotcha. So tell I guess our listeners, me, whatever, tell us a little bit about what a director of intake and access does at a behavioral health agency.
I'm not quite sure.
What does life look like with that?
So I have... part of my role is to develop processes and consistent things that we do to make sure that we're providing the best service for these clients, meeting them where they are. I think you had once said to me the best time to get them help is when they ask. And so that's sort of the mantra that I sort of push off on the people that work with me. So what I do is I keep my eye on all of those schedules, and there's 30-some schedules a day now that we're looking at, that we're working with. So that's what life is like. I make sure people are getting in. I measure that as our response. We have quality standards that we meet and try to meet, and I keep a look at that. Plus, when people are off, I step in and answer the phone. So, and when somebody else is off, then somebody else steps in. It's a very much a team effort.
Yeah. How we'll dive back into that, because I want to hear a little bit more about that, because one of the main things we hear about as far as feedback is the lack of access. Right? We hear we had an episode a couple episodes back where we were talking about rural America and how difficult it is to access care there, and I know here in New England we've experienced that as well. And so I want to hear a little bit more about what accessing care looks like, but tell us a little bit more about how you ended up in behavioral health. I know you spent a lot of time in the healthcare world, and so maybe if you want to tell us a little bit about your previous life and in healthcare, and then now your current life in behavioral healthcare, and what the difference is there. Is there a difference?
There are similarities and there's big differences. So like this, there's a lot of similarity, but the differences are huge, right? It's not like, oh, that's a little different. It's a lot different. So for my whole career, pretty much, I've worked in healthcare administration as a consultant or in hospitals or in managed care companies. I have a weird set of skills, I guess, kind of a background, because I've covered
like a Liam Neeson particular set of skills.
That's
kind
right.
Of thing. Yeah.
So it's like I have, I just have had an experience with all of those kind of things, set up billing companies, and so what I was doing is actually would come in and set those businesses up or staff those businesses, or a hospital would hire me to run a service line, or just whatever. I traveled a lot to do that. So I was in Dallas working, and I am originally from Ohio. So I was in Dallas working and had been there 11 years and was recruited to another behavioral health company in Ohio, who relocated me. My family had all moved back to Ohio, so I came back, and then like a couple of years later, we started Anew Behavioral Health. So, but as far as processes and risk management and things like that, it's the same. The things you have to look out for. It's sort of elevated in the behavioral health world, just because the privacy it's important everywhere, but you have to be very careful. These are people, they're very fragile, and you need to make sure they understand, so we communicate with our clients past the intake. We communicate if somebody wants their records. We communicate if they want their records. All of those things. So that's different. On the behavioral health side, what I found was it's the scheduling. I've set up intake departments before, like a central intake, in a couple different medical companies or hospitals, things like that. It's different here. And number one, the immediate volume, it just blow you off your chair. I mean, it's just like, okay, let's turn on the phones, that kind of stuff. And so the other thing that's different about it is the things that we hear and what we find out and how we respond to that. And the piece of educating people, because in this company, at least, it's an integrated company that's truly integrated. So for us, it's not just intake. That's just the beginning. Yep. And there's so many other things we offer that we try to make sure and check in with them on those things as well.
Yeah. Yeah, you'd made a couple of comments about, it's kind of different with the clientele and it's different with these patients, and maybe they bring something different in terms of what their needs are to kind of get connected to services versus somebody who has a broken arm or somebody who's dealing with a chronic condition, and they go and see their specialist. So we hear a lot of studies and read a lot of, the data on access to care as a problem. And so what are you actually seeing out of this clientele that is preventing them from getting care or preventing them from taking full advantage of the care that's available? Because I think there's some debate in the field about, like, is there enough care available, or is it like client issues where there's care available, but it's not being utilized? I mean, what are you seeing in actual terms from these clients that kind of can serve as a barrier to them getting high quality care?
I can't speak for them per se. I can tell you what we hear and see. So some of it, I think, from what I've heard from clients myself, is fear. They don't know what it's really all about. They don't really know if they need it. Sometimes my wife told me to call, that kind of thing, or my husband wants, whatever. And then when they get here, it's a completely different story. Some of it, I think, is that they just don't understand that it is out there. There are people available, and sometimes I've heard people be very discouraged, especially at this office in Keene when I've worked over here. And, just disclosure, I work out of the Claremont office most of the time.
So Claremont, New Hampshire. I mean, this is no joke. We have a nationwide audience. I think you need to be
Claremont, New Hampshire, and I also direct the Ohio teams as well. So it's a little different, but we learn from each other every day. But what I can tell you is that people get really discouraged because they tell me that it's 6-month wait. Oh, wow. It could just be volume, and I think part of that is because we've opened back up for in-person services. Okay. And so we're fortunate that our therapists are in person and in telehealth. We always offer them an option. But I think some of it is fear. We get our clients from a lot of different ways. We get them sometimes on a court order. Mm-hmm. We'll hear from the probation department or whatever. We get them from a judge's order for an assessment, or sometimes they're in a rehab facility with our SUD clients or clients that are seeking SUD treatment someplace else. Yeah. We get them from from walking in off the street. Yeah. And those we consider those community clients. And so, I mean, they come from every. Sometimes we don't get the referral. We don't get to speak with the client. We speak with the program. Right. And then ultimately we speak with the client. So what I hear from them is some of them are just at the edge of their rope. Some of them are really proud that they finished their treatment and they want to stay with us. We have a really great retention rate with these clients that have been in a program, and we see them there. And then when they're done and out of outpatient, theoretically ready to go on their own, they still want to stay with us for care. And so that, I think, is a great honor and a testimony to how wonderful they feel when they tell us they feel better when they're here. So that's great.
Yeah, that's the whole point.
Yeah, that's not intake, though. That's y'all. Yeah. It's intake that kind of gets it ready to go,
But, yeah, I mean, you say that, except the power of first impressions and the power of early experiences, right? So, I mean, it sounds really great to have a Dr. Boggs or Dr. Montoya ready to do the services and, or a nurse ready to do the intake. But the reality of it is the first 2 or 3 contacts are going to be your care coordinators, the people at the front door, the Emilys, the Jennies, the Heathers. And I think, clinical skill aside, I think part of what makes our team special and part of what makes just a great intake experience is that warmth and that ability to have a strong first impression, and we care, and it's not just sort of head down, name, social security number, birth date, insurance card, thank you, but to be able to actually connect. So, yeah.
Well, and that actually, when I interview people for this role, and we have positions open right now in different places, just letting you know.
ANEWBH.com, careers link. Yeah.
Yeah. So we have those open. But when I ask questions that I get an empathetic response, or I get well, they should do this kind of response. That's a really good sort of a way to clear the things out, make it all even. If anybody can do this job if they're willing to put in the time and they understand the clients and the process, and they're willing to take all of the steps that's required. And this is really lots of steps to do it right for our clients. We want to make sure we've covered all of those bases with them. And so when I hear on the surveys, we have people doing surveys. When I hear so-and-so was so kind to me, to me, that's, the best day ever for them. And they're very proud of themselves too, that people notice. Because they're not here to be noticed. They're here to help. And these truly are helpers. And it makes a complete difference. It really does.
Yeah, I think that role, that first contact, it's emblematic of that phrase, like, nobody cares how much you know until they know how much you care.
Right. Yeah. Well, and studies show that if, a lot of people will leave if they have a bad first experience. And so we want to make sure that, that they get to know us. They know my team's names. They know who they are, who they call. And that's why our model is a central intake model with a face-forward presence, with every site that we have open has that person in place that they will get to know as they come in, and it makes a difference.
And that's what we hear. Like when one of your folks, and I say girls because right now all of our care coordinators are female, but
Coming soon.
Coming soon. We're going to get Ian to do it. So he does everything else. Ian needs a fourth job. So
Thank you.
no, but they say when one of your girls is out, like vacation, or God forbid they take a mental health day or like do something for themselves, it's sort of like, where's Jenny? Where's Heather? Where's Emily? You know what I mean? It totally throws them off, and it is actually a nice compliment to what a steadying presence they are, and how local they must feel. Like, we're here in your neighborhood, in your community. I know there's other agencies that may be bigger and do everything online and but I just don't think you can replace that human to human across the table.
No, it's not. And, we still, the last place I did central intake, we still had people at the front, but they missed having that one-on-one getting. And the thing is, intake, you have to be a problem solver because you have a client that needs something very specific, and you've got X amount of therapists that some of them have that and some of them don't. Maybe they'll do that particular time for that client. So that's what you're constantly doing, is looking at everything you have. I feel like it's an air traffic controller kind of thing. Yeah. Everything's incoming, or leaving, and how are we going to get that and to get it on time and then get the person where they need to be, because we have providers that we take care of too.
Right.
So the intake provider depends on us to make sure that's a solid appointment, that the client understands, it's going to be an hour, it's going to be this, whatever. Right. And so we're in constant communication with our providers during the day as their day goes on. So it's not just those phone calls from clients. Intake and client access also make sure the client has access.
Right.
Right. Not just accessing other service.
Sure.
So luckily, Anew has done a great job of putting in computers all over the place that people can come in and use if theirs isn't working, and things like that. But it's a long day every day. It's a lot.
Yeah. How did you guys deal with COVID? I mean, I know it's not sort of as present as it was, but we're talking about personal touches. We're talking about access points. What did life look like during
Actually,
COVID?
I think it was, I felt, because I was doing a lot of one-on-one at that point during COVID, before we had staffed up, and, our volume went crazy. But I felt actually more connected to clients because that was the only way they could talk to me, is if they called. They have my cell phone number, a lot of them. The programs, and I think it was a calmer kind of thing. The client wasn't calm. They were worried. They had significant issues with that. Some clients wanted in-person services and were frantic when they couldn't have them, and that was very hard. And to the credit of a lot of our therapists, and I guess all of them, I haven't asked them all, but there were some that I had dealt with that maybe they had seen that therapist in the past and they wanted to reconnect, and they were like, really in a panic because of the COVID situation. Yeah. And I would text that therapist and they would call them right then. I got 5 minutes, let me just call them. Because then they could tell me how fast they needed to be seen. They need to be seen today. What do I need to do? If you're busy, could another provider see him? Is this something that we need to, because we're not clinicians, but we have fantastic clinicians that never mind that question. Yeah, just ask me. I'm happy to help. So
it had, and I'm old enough, you're old enough, it's kind of a post 9/11 feel, remember 9/11 happened, obviously terrible, but I got to tell you, there was nothing like driving after 9/11, like for 6 months, or going to the grocery store, or interacting with, you're right. Everybody was very collaborative, and like, we're all in this together. And I will tell you, like, even though we were physically separated, I did feel that during COVID to a certain degree, right? People were just genuinely concerned about, I'm going to keep you safe, you keep me safe, and that kind of stuff. But yet, I'm willing to go the extra mile for you because I know you're going through it, because I'm going through it too. That sense of community was I don't know, exceptional.
Yeah, I think that we take care of clients as young as 3, and And so I think that it seemed like that particular book of business, as it were, that particular age group of clients, that really expanded during that period of time. And so those are handled a little differently, and all of us were like, yes, we'll get in somebody right now. So, but yeah, it just, it's almost like it was a dream, right?
Yeah.
And now when but still there's some people that, prefer to stay home. They don't,
Sure.
and we honor that. And absolutely, in our offices, we're set up for, we're meeting the standards of wearing masks and, cleaning and, hand sanitizer, all of those things that we're required to do. And so we feel comfortable with that. And I have witnessed firsthand, without my prompting, when I've been training somebody, them say, a client walk in and she'd say, do you need a mask? And she moved her mask and she goes, are you comfortable with me taking this down to talk to you, even though it was through glass?
Gotcha.
Right? And I thought, that's a good touch.
Nice.
Good for you.
Well, and you'd mentioned it a little bit, but for those, I guess, that wouldn't know, Cathy also has direct client experience working as a case manager, and that was during COVID too. And one of the things I thought was amazing during COVID was that on the provider side, nobody really had to be begged into work, right? Like, I mean, there were certainly times it was like, well, I'm a little more comfortable working from home for a while, but shots or not, people were like, I'm here to help. And it's like, the old Mr. Rogers line, find the helpers. Like whenever there's a problem, find the helpers. There will always be helpers. And it felt like we had a lot of helpers. And so what was that like for you? Because I know you were kind of in the firing line, direct experience. So kind of a two-pronged question. What was it like being front and center during COVID and doing case management? And then two, can you kind of talk about case management a little bit and what you learned during that time and how you apply it to the front end experience now? Because I think there's a really nice connection between those two. Wow.
Yeah, when we started the company, I was one of those people that was kind of there with y'all. And we needed a case manager. I have a master's degree. And you said, hey, let's train you to do this. Yeah. So Matt and you, Dr. Boggs, all kind of huddled around and said, so that's what happened. Yeah. And so I had read all the books and I got all the stuff and did the credentialing and stuff. Yeah. And then I had to sit there with a client for the first time. and honestly, it was just like, so first off, my first impression was that I felt at first like when I had certain questions to ask them, like, tell me about your history. What do you need? How can I help? Here's what case management can do for you. It felt to me a little bit like they were sort of repeating a story they'd told 100 times. Wow. And then I would respond to them. And then I learned to respond to them this way because this is what happened. I'd ask them just something completely off the cuff about, this or that. They're just used to having somebody write down what they're saying. And I'm actually interacting with them and sharing with them, wow, that was really perceptive of you or things like that. Then it became more of a conversation. Yeah. And so that everybody was very nervous, especially in the programs, because people would come in, be admitted, to residential treatment all the time. And these clients of mine, they had been on the streets, they'd lived there, or they'd been in bad situations. So they knew the kind of circumstances in which they might have been living. And so there was a constant fear among them. And I know that we tried to do some work in Mount Vernon in one of those about clients that really wanted to kind of separate, the new people from the old people because the old people had been tested and, stuff like that. Right. And we got past that. But so they responded the same way everybody else did about it. They weren't sure what was going on. Right. And honestly, it took a second, sort of a back seat to their particular condition and the struggles that led them there. When you first go into that rehab situation, that's when they would call me. Or if there was a crisis and I was home 2 hours away, they would call me. And honestly, I haven't done that for, what has it been, like a year and a half?
It feels like a minute, yeah.
Yeah, they still call me. These clients still do, just to chat and see how things are going and let me know that they're okay. So I'm really, that was a very difficult time in my life, but a wonderful thing. It completely changed the way I view all of it. I am forever grateful that I was able to do that. I had never done that. I was non-clinical, and I was the first person in hospitals when I was working, emergency departments. I'm not clinical, but I can get somebody clinical kind of thing. And I'm not particularly clinical. There's a limit to what case management can do. Right. And I was well aware of that, and I didn't. I connected with them, and I heard their stories. And having written policies and processes for another behavioral health company and this behavioral health company, I didn't really understand the impact of those things that limited things, so we changed those right away. Being a clinician-owned company, everything goes client first. But they would tell me things, and whatever had happened in my day or week or month, I didn't even have any memory of it at that moment. I was just so in awe of the strength of these people. And I worked intermittently, I worked in the men's houses, but mostly with the women's houses. Right. And then women as a community, a client. And I mean, every day I was just like, unbelievable. And you can't respond the way you really feel unless you're like me and you just burst into tears and say, "Are you kidding me, really?" Kind of thing. But I'm forever grateful for it. I mean, it was a lot of work. It was a lot of heartbreak, and a lot of sad things happened during that time, if you'll recall. But with our clients, after they had left and things like that. But I'm thankful that I know him, and I'm forever grateful for have done that. Changed everything I think about with this.
When you talk about things happening, you talk about clients passing, and and that's the harsh reality of a lot of this, right? Isn't that why, kind of circling back around to what you said earlier about when you need to respond to them in terms of needing help is when they ask for help, because versus other types of appointments, if they miss it and it's a major inconvenience. Because, okay, I'll come back in 2 weeks, or in our world, you come back in 3 months because everybody's so full. But in the mental health, and especially in the addiction side, you have to understand, like, a missed appointment can end with the loss of life, and does. I mean, it's, we work with a partnership in Ohio. I won't really reveal the name, but they do a good job in recovery services. And, they like put locks on gates and things like that for people that they've lost. And there's not 2 of them. There's quite a few. And so it's hard in the world of work to kind of think about things in terms of like life or death basis. And nobody bears the pressure of, if you didn't get a slot for this client to be seen, it's your fault, or any of that kind of nonsense. But there are consequences to this kind of stuff. And, there's real urgency, though.
You do think that. You don't, and for me, and the first person that instantly comes to my mind, she had already left. I had been her case manager. She had all the services. She wanted them all. She actively participated. Beautiful person. And then after a couple of months, and she was actually working in addiction. Yeah. She was working as like a case manager in a program. Yeah. So it wasn't like she wasn't getting services, at least being around that kind of thing. It just... It's a horrible, horrible thing, man. Yeah. It really is. Well, and I love her, and I'll always love her.
Yeah. And the way I can connect with you on that story, like my first kind of big boy job, I was working at a medically assisted treatment clinic in Richmond, Indiana.
Oh, that's auspicious, isn't it?
Different world of Matt nowadays, right? Like, things have changed, but they were dealing basically solely in methadone. And methadone is very powerful and very scary in terms of some of the impact, because while it does do a good job of blocking the opiate receptors physically, psychologically, a lot of those behaviors are still in place, and those patterns are still in place. And for a lot of people that are addicted, their drug of choice is just simply more, right? That's their drug of choice.
I guess. I'm not a clinician.
No, but you're observant. And so you think about somebody who's using an opiate and their opiate receptors are blocked and a little bit's not working. So what if I take more? And if that doesn't work, what if I take more than that? And so,
I get it. Yeah.
And so they overdose and they die. And I was, early 20s and I lost 6 clients my first year. And,
It break your heart.
It's tough. It's not, it's nothing you can really prepare for. You said you read all the books. I'd read all the books. I've met with the guys who wrote the books, and this is what it's going to be like. But you don't know.
Yeah. So, well, that client of mine, the first one, and I've only had 2, but and I haven't been doing case management for a year and a half. So one of them was like way after my time, but I just knew her from that. But anyway, I remember calling you, calling Dr. Boggs, calling everybody like, can we just have a group call so Cathy can talk about how she feels about this? Sure. But I mean, because again, and I had this working in an emergency department. There's something called critical incident stress debriefing that you arrange if a patient expires, especially in a pediatric facility, for the caregivers and things. And it's a great thing, and it's necessary. It's much needed. And so in that role at that emergency department, I had been to school. I hadn't been to that school, and I wasn't a clinician. So, but I was right there when those things would happen. Yeah. And so they go to critical incident thing, and I'm like, can I see your notes? Because I don't know how and that's ultimately what caused me to have to look someplace else. I just couldn't do it anymore. It just got more and more aggressively awful.
Yeah. And this is just in traditional healthcare settings too. Yeah.
Yes. So, but the light at the end of the tunnel is that now they do offer that for, people like administrators like myself, that are right there adjacent to, or in my case, because of the trauma registry right there. So, but it's a thing.
Yeah, it's a thing.
So I think that, people come to us and they are either, they're very jubilant, but I find that that's not necessarily the case. Right. They are, and, to your point about access and all of these things, I tell this story all the time because it's 100% true. And I think when I write processes for my team, or we talk in ops meetings about what could we do differently and things like that, I always think about this, and I think that doesn't have to happen. Had a client that called in, wanted to be a community client, so we scheduled her, but she had to run over to get her paperwork, so that she didn't. So we couldn't put her on the schedule because you have to have consents and things like that. This happened like 3 times, and then the third time, she's actually in her car on the street, and my team member, girl that worked with me, actually, they'd become sort of phone friends on this, come on over kind of thing. She actually ran out in the rain and brought her paperwork. She couldn't bring herself to come in. So it continued for like 3 or 4 more weeks. And then her appointment, and she called and said, I can't, and got in her car and left. But see, nobody said, well, then forget her, Right. They were just like, when she's ready, she's ready, we'll be ready. And that's exactly what I called her. And I said, when you're ready, we'll be ready. Just, give us a call. So 2 times later, after 2 months, she finally made it in, and she still to this day sees us. So I think about that. Sometimes they're like that. And even that they may seem jubilant. When you walk through those doors and you face the fact that you're really now going to be bringing up those things. Right. And then what we also see in the face first world of clients being in the office is that particular person changes over time. Yeah. When it gets really tough, it's really obvious to us, and then, a couple of sessions later, they've worked through it with their therapist, and we're real happy to see that.
Sure. Yeah. It's easy to think about, like you talk about, processes and things of that nature. And it's easy to think about, well, why don't they just blank, right? Like, why don't they just fill out their paperwork on the portal? Or why don't they just plan ahead? They knew that we couldn't have a meet availability. Well,
because they're human, right?
Or like, it's only like 17 pages in the consent
12.
packet. What's the big deal, right? But you have to think about meeting people where they are. And that's one of the solution focused tenets we talked about. It's like, you just meet the client where they're at, right? Without judgment. And if driving to the block is as good as I can do, we'll meet you there and that's fine. Right. I do think sometimes processes are necessary, right? But it's really hard because you experienced, great on paper, this makes sense, right? I'm a sports guy, so every play in the huddle is a touchdown. Oh, this is gonna work, right? And then life starts happening and stuff like that. So being able to maintain that flexibility and
I don't put never in a process, right? So when I write a process, I don't say never.
Yeah.
Never go out to the car. Yeah.
Always a never. Yeah. Those work great for everybody.
Yeah. Try to do it this way. So there's some flexibility. There are some hard and fast processes that we have to have. The state requires it. Ethically, we require it. But when it comes to how to get a client in, or how to refer them someplace to a case manager or whatever, their therapist, it's not never listen to that. We never say that. Just, keep your ears open. And the thing that's great is my team now is at the point where they want to know more. What else can I ask? Mm-hmm. What else can we do? They tell me every day at the end of the day, I get these texts man, I got slammed today, but what else can I do tomorrow? Kind of stuff. Yeah. So,
no, that's great. That's great. So I think of, the antidote to a lot of anxiety is kind of education, right? So if somebody's listening to this and they're one of those people who are sitting in the car, not ready yet to walk in, and maybe some of that has to do with, I don't know what I'm signing up for. I don't know what this is going to look like. I don't know what I'm in for. So not speaking clinically, although you've had some of the experiences case management wise, but just if you could just kind of educate people from that whole start of I think I need some help to actually getting the help. What are they signing up for? What does that look like? What are they in for in terms of getting connected to services?
Okay. So basically how to get services?
I guess, yeah. So if I'm a complete novice and I have no knowledge of this whatsoever, I've never gotten help, but I'm now thinking that I want to do that. But like anything else, oh gosh, this is going to be a process. How hard is this going to be, and what am I really going to go through?
It's going to be a lot of my time, things like that.
Yeah. What am I really going to go through to get connected? Because you don't just walk in and start talking to the therapist in 5 minutes. What happens?
Well, what we do is, and again, it depends on the client, depending upon what they're here for. Some people just want a short-term kind of burst of therapy, thinking they need to get something resolved in their head or whatever. Those clients are completely different in the way they drive that whole thing. They've been there before, not with us maybe, but they're switching agencies. They know the ropes. They just need to do it this way. And so we just kind of guide them where they need to go. But for most people, you can contact us in a lot of different ways. Yeah. So are you speaking about like a community client, not just an agency client?
Just to clear it up, when you say community client, you're talking about somebody who just lives in the community.
Lives in the community.
Outpatient. When you're talking about agency client, you're talking about somebody who is already getting services from another agency and wants to add to their services or have companion services.
So like if they're in a rehab service or outpatient aftercare, things like that, or if they want to switch to us from a different therapist and things like that, those are referred in.
Yeah.
The community client calls in.
Gotcha. Yeah. So I guess maybe more community client, right? Because somebody's working with the agency.
I never want to say outpatient because like outpatient is, a lot of the programs have outpatient clients, and I didn't want us to get confused. Is it their client or our client,
Yeah, let's just think somebody from the neighborhood. I drove by, saw the sign.
Yeah, we get that a lot.
Yeah.
And so we talk to them and just ask them a few things like, are you interested in the office, or if you're interested, would telehealth be okay for your intake and things like that? We explain what the difference is. So we spend about 5 minutes just kind of letting them know how it's going to work. Then we get their name and their demographics, and the same thing any doctor's office does when they set up a client, a new person. And then what we do is run their insurance to make sure there's no problem there. If there is, then we try it again. We work. Some people will come in and bring their insurance card and say, "No, I swear it worked." Yeah. So, and we're thankful for that.
Yeah.
So then we get an email address. A lot of our stuff is electronic to them, and then we get them scheduled right then. It's not like. Back in the day, we could get them scheduled in a couple of days. Now, we have a lot of therapists, so we are very, very lucky. But so we give them an option between in-person. It takes longer to get an in-person therapist. You could do your intake on a telehealth visit and then switch to an in-person therapy, however they want to do it. And so we get them scheduled, and then we check. This is the best case scenario, right? We check to make sure if intake's done it, if the paperwork is in there the day before the appointment. If not, we're back on the phone with them because we can't see them until then. We send them a reminder. We call them in the morning. We do everything we can to get them on that appointment. And then the appointment happens, and then the therapist makes the recommendations for further care, in which case if the therapist says client needs to have a psychiatric evaluation for medication, we get that scheduled. So that's all that intake thing. And then, we just continue to monitor that. And then after that point, they're an existing client. Yeah. They may talk to other people other than us.
Sure. Yeah. So when you hearkening back to the earlier conversations about barriers to care and, barriers to access, I mean, when you describe the process there, it sounds pretty logical and pretty simple. So from your perspective, where are those barriers? I'm sure they're real, but I'm just wondering.
Internet, their cell phones. A lot of our clients have kind of wonky cell phones, or their text phones or something like that. Gotcha. And so they can't do like a Doxy is our program that we use for our telemed. Gotcha. So they can't do
video
that.
Conferencing.
Video conferencing. So to their credit, Anew has recognized that. So we just say, come on over to the office, or we have a case manager. If they're engaged with them, we contact that guy or girl, and she goes and gets them and brings them in. And then after they're established, then that can sometimes be just a phone conversation, things. But that transportation, they want to be there in person. We've had clients that have walked like 2 miles to their appointment because their ride faltered, but they wanted to get there, so they'll call us and say, I'm going to be 10 minutes late. Sometimes it's their work schedule, but again, we've countered that by getting therapists that work till 7, 8, 9 o'clock at night, every Saturday, every Sunday. Incredible. Yeah, they're willing to do that. So there's not a day that we're not seeing clients every week. But so that's why it's so important that we spend a minute or two just finding out, like I'll say, what days do you work? What's the best day for you? And I note that in the chart. So theoretically, when they get scheduled again. The no-show clients, it's tough. It's tough with the no-show clients. That's difficult for our providers.
Gotcha. So no-show just meaning people just appointment time and they don't log on, they don't show up?
Yeah, I'll be there, or you call them right before. And actually, the way we do it, which is really different than any other model I've done, is that we're working that schedule all day, meaning that schedule's been published, but the provider will call one of us and say, hey, my patient's not on. So we start calling them, and we'll text. We use email, we'll call them to try to salvage that appointment. If we get that a couple of times, the provider gets a little concerned, so they'll go out of their way to try to reach them too. So we do everything we can to never have to discharge a client. I mean, we sit down and talk to him, say, maybe we're scheduling the wrong day, or do we need this, But so that's why I say that intake and scheduling at Anew Behavioral Health is a lot different because we're working everything all the time. I could have 10 people and barely keep up,
Yeah. I suppose it's one of those good problems to have.
Yeah. Oh yeah. And to us, it's like a challenge, If you get it together at the end of the day, you feel pretty good.
Well, I think, and you talk about everybody involved in leadership is a clinician or has been a clinician or has been involved in client care. And I just think that the one things that I love the most about Anew is sort of the unbridled ambition. We say things like all and any, like we want to help everybody. We want to, anybody, we'll find, all pay sources. And that comes with that sounds good on like a poster, right? But that brings with it some really heavy challenges in terms of actual execution.
Yeah, we don't think about how we're going to do all. Well, I will tell you a great compliment today. I was interviewing someone for this basically an intake client coordinator position. She's actually in school to do, she's getting her master's in therapy or counseling or something like that. And she goes, I didn't think you would call me. And I said, well, she had some experience we were interested in. And, we're not required to have that degree to do this job. And I said, she goes, I didn't think you called me. And I says, why did you apply for this job if this is what you're doing? She goes, because I knew I needed to know this to be a good clinician. I knew that I needed to know how to get him there, how to get him in, how to do it. She goes, I knew that I needed to know this. And I also knew that when I finish my schooling, I want to work for you guys.
Yeah,
so
that's cool.
Because she's heard of you in this it's actually in the Keene area. She's heard of the company. She's like, so if you don't hire me for this job, she goes, just look for my name because everything you post, I'm going to apply for. But I think that's really great that as a clinician, she's like, I knew I needed to know this. I needed to know how to do this whole intake thing. So
yeah, that vision is rare for sure. Yeah. So with your, kind of to reset a little bit, and then thank you for that description, because I think that, like I said, it sounds very easy, logical. Sounds like your folks are holding hands and walking people through the process. There's no,
we're trying
by 4:00 or don't call us. There's really not a lot of hard stops. It feels like we can work with most any individual situation. Yeah. From your perspective, so thinking about being in the field for a while in terms of healthcare being the umbrella, I'm certain there was some experience and some awareness of behavioral health when you were on the traditional healthcare side of the house, emergency rooms and things like that. Sure. And then now, obviously, a deeper experience and deeper understanding, fully committed to the behavioral health side. I'm interested in your experience, your perspective in terms of what has changed over time in terms of how it was looked at and how you sort of encountered behavioral health or thought about behavioral health when you were on the traditional healthcare side of the house, and how you think about it now, or how maybe things have modernized or try to keep up in terms of the field. Because I think the integration and interplay between traditional healthcare systems and behavioral healthcare systems is essential. Behavioral health, mental health is health, right? And we're starting to see now that mind-body connection, that a lot of the psychological problems are influencing a lot of the traditional medical conditions and vice versa. So I'm curious how that was spoken about, experienced earlier in your career versus how you look at it now.
Oh, way, way different. And I think society looks at it differently now, too. Oh. There's so much more acceptance, for that. But in a pediatric environment, they have social workers and they have therapists and things, which is fantastic.
More for an abuse intervention type, right?
Those are social workers, yes. But also they had behavioral health, some people that were counseling clients and things like that. But it was usually very ill children. Yeah. That they would help them with that. But some of them were just behavioral health issues. In the adult world, when I worked at and they saw children as well, but they were not considered specialty pediatric hospitals. Yeah. It was tough because there was only a few places they could go. And if they had a psych ward, back in the day, they all had psych wards, but they were hidden away, locked down.
Yeah, locked up.
Mm-hmm, and stuff like that. So you didn't really go up there, and to admit a client, they were doing a lot of that straight out of the ER. What I did find out, and this is a completely different job, when I would do auditing on the provider side for United Healthcare. A lot of these pediatricians and family doctors were doing behavioral health to the best of their ability in their office because they couldn't figure out where to see their clients. And a lot of providers back in those days, they were not, and again, these are the days, not if you want to look it up, you're going to have to look way back. They really didn't have pediatric specialty. They were not as prevalent as adult psychiatrists, and that was a completely different thing. And it was, Right. And then for those that had a comorbidity, or they had a dual diagnosis of drug addiction and behavioral health, it was treated completely separately. It wasn't an integrated treatment. They go here for that and here for that. And they were, some of them, these clients were well known in different emergency departments when they would come in.
Gotcha.
And so I think the treatment was the best they could do, but a lot of those clients were already incarcerated and things like that, and those are treated differently. Right now, I'm seeing a lot of, my boss said that maybe I needed to talk to somebody because I was sad and things like that. And if you look at social media, and even TV and different celebrities that are now coming out, they said that, I heard a quote the other day about behavioral health is like the new, it's like the new Twitter or something. Like everybody wants to, talk about their behavioral health experience. Yeah. And good for them.
Yeah, I think that's a huge advancement. I mean, even when I was growing up, nobody talked about. I didn't know anybody in school. This is through high school. This is not like kindergarten. Through high school, I didn't know anybody who ever said the word depression. Anxiety was not talked about.
Crazy.
Yeah, or emo.
When I was growing up, we had kids that we grew up with, and if their mom was depressed, and now in retrospect, she probably was. She never came out of the house. She just kind of looked one eye. She's crazy. Don't go over there. So it was like, stay away. She's crazy, and nobody knew her. Right. There's one lady I'm speaking of in particular, and but even in your own families. You had people in your family that you said, I think he's crazy, right, because he acts a certain way or whatever. And certainly the terminology used was much more brusque and inappropriate. Now we actually do have and know the words. Yeah. And
which is funny because we go from a stigmatized environment where like nobody knows the words and that's a crazy person, and like think about the shame and the hurt that must have caused people to be labeled that way. Like, I'm just struggling, but no, you are. Yeah. You don't have symptoms. You are.
And
right?
people that have no ability to know if that's true or not are diagnosing you right here. You're crazy. Right, what? Right. So to me, that's really heartbreaking. And I really see that. I saw that a lot in my case management clients was the shame, and they surrendered to it, and then they fought back and came in to get help, right? If everybody says I'm dirty, I must be dirty. If everybody says I'm bad, I must be bad. And then you see the choices they make in life that basically are fulfilling what they thought of themselves, right? Well, it's like you said, if your perception of yourself is this, you'll behave in a certain way, and that's true.
The most powerful stimulus and sort of dopamine triggering event to the brain is to be able to say, I knew it, right? And even if it's in a negative way. I
use it a lot.
Yeah. I knew you did. No, even if it's in a negative perception, right? So like you have to be very careful with labels. You have to be very careful with identity, because if you, like you said, surrender to that label, and now I am. Like we talk a lot about fixed states versus transitional states. You may be in a bad place now. You may be depressed now. You may be sad now, but you're not a depressed person, because that's like a fixed state. Because if you adopt that identity, you're going to go out and prove it right over and over and over, so that the brain can get a sense of order, right? That chaos versus order. And it's like, at least it was predictable. I knew it. I knew this was going to happen, right? Like winners like find a way to win. They don't stop till they win because it fits. There's no cognitive dissonance. Yeah. I knew I was going to win, even if they lost. You hear all these stories, Abraham Lincoln lost every election until he won the presidency or whatever the hell, but that's a winner. He's going to hang in there. But the opposite is true too. If you adopt that label of a failure and loser or junkie in the addiction side, like, you're going to find a way to prove yourself right. So I think that's what you're talking about.
Well, and also I think that it keeps people from being their best self, having their best day. I mean, it's like a bad day, not a bad life kind of thing. But because what happens is, and I've heard this among people that even call in, not too bad considering how depressed I am. Yes. Right? Yes. Well, I think it was great. Just think of how much I could have done had I not had this in my history, or if somebody hadn't treated me this way. Sure. So to me, I hear those people and my heart goes out to them, because they're still holding it so close. Sure. And it's such a toxic thing that they feel is keeping them safe. Yeah. And it's not helpful, but it's not my place to say, put that down. Right. But I will put a note to the therapist. Patient said this.
Well, and I think it's fun to introduce, and it's effective too, to introduce time limits on it, right? So like, oh, I'm really sorry to hear that you're depressed right now. Yeah. Right. And it's gentle, it's sort of indirect, but it implies that there will be a time when you're not. And we do see a lot of change. I mean, you mentioned about, your front desk folks and the care coordinator seeing them and kind of knowing, and then they come back, that cyclical nature. That's all of us, right? Good days and bad days. And
there was one, the lady in Keene was off for a little bit, and a client was sitting out there waiting for something. And another client came in to check in. He goes, "Oh, where's Heather?" It was Heather.
Yeah.
And the guy that was sitting there was on his phone. He goes, "She's in Costa Rica." And she was not. But the thing was, they like all knew,
it's a community.
she had a relationship with them. They all, and I was working there for a couple of weeks, or it seemed like a couple of weeks. It's a busy office.
Sure.
But it was so funny because people have recurring appointments. A therapist will say, "I'll see you every Wednesday at 10." And so that group, the 10 o'clock group, knew each other, and they'd start talking. And then here come the 11 o'clock. It was just so great, so great.
I think it's great in terms of sense of community too, right? They feel connected.
Yeah.
That's why we always want to have the front door. I just would never want to go completely digital, even if the efficiencies were through the roof, because you lose something. We lost something for a period of time with COVID when people didn't feel safe walking through that front door. You always got to have a place where you belong, where everybody knows your name, like the old Cheers thing, right?
I mean, I know that you saw some clients back and forth during COVID. I had more difficulty connecting behind a mask, that kind of stuff. And then invariably, as they're telling you their story, there's a lot of tears, so you can't really comfort them. Yeah. Or they'd raise their mask up, right. And you're like, "What are you doing over there?"
I'm a bad one to talk about this. I hated the masks. I thought,
I did too.
I just hated it. I liked it at the grocery store. I could put my headphones in my mask and like nobody kind of like bothers you, or something. I hated it. I felt, I don't know. I mean, we're not going to go political. It's you see, I voted today, so we're heavy political here, and we only vote for people who support with their votes and their dollars mental health and addiction treatment. I don't care red, blue, purple, anything like that, and I don't want people I don't want people falling for this trick of, well, we're going to increase access to care. We've all got waiting lists as long as our leg. Access is not the issue. It's you've got to support the system in a way that allows funding to then encourage people to come work and pursue these careers, and allows folks that are in the game, like Anew and everybody else, forget competition, but they can just invest in their companies and open up more doors and offer more help and, pay their employees better.
Think about if you were just in your undergraduate deciding what to do for graduate school, if you were going to go that way. Yeah. And, people are always now very open about, and then I did this, and then this happened, and I was sad, da, 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 da. Would you choose that? Would you choose to sit for 8 hours and just bear the weight of that, or would you go work in the forest ranger as a forest ranger? Would you go? There's so many different options. Sure. So I think that those people that do that say nope. A lot of people we have that work with us just want to help, don't really have that. They just want to help. They may have had an experience in their family that was more, lends itself to this business, and so they're paying it forward in that way. Yeah. But some people, the new people that have come in and stuff, it takes a special person to, and I just feel like they just seem like they're different in the morning than they are at the end of the day.
Sure, you wear it.
Yeah, and so I see them come in, and then at the end of the day, they're a little different because they are bearing that. If they're any, if they're, they're paying attention, and then I just feel like, I mean, what a noble job, because I did it for 6 months, and I would cry every day.
We still need a debrief. There's some trauma that's lingering.
No,
There's some
not trauma.
vicarious.
I just always wondered, did I do enough? I worry about them. Are they still doing okay? Yeah. And in fact, KC, since we had a lot of shared clients, and now I see them on the schedule, and I'll say, "Hey, they doing okay? Yeah, they're doing fine. They said hi to you," kind of stuff. So.
But but that's the thing. So you're talking about this whole universe out there that's almost kind of behind the scenes, right? Because the agencies are very kind of quiet and set off, and it's not a very public thing and confidentiality. But there is a whole army of helpers out there that need help, and we have to find a way to help the helpers. Damn it, I don't want to hear any more about tax credits, and I don't want to hear any more about like job creation. Find the helpers and help The helpers.
Yes.
Those people need somebody to lift that weight off of them at the end of the day. They need agencies that can support extra vacation days. The idea that, I'm not knocking any job, but I'm just talking about the emotional toll, right? Yeah. And the idea that somebody can punch a clock, punch punch a bumper on an assembly line, things like that. The idea that that person needs as much emotional time off and away as somebody who sits there and does it for 8 hours a day. Yeah. Have your wife or your significant other break down on you one time for 1 hour and think about how you feel at the end of that hour. And that's obviously somebody you care about on a different level. Now do that 39 more times in a row. That's a week. Yeah. That's a week. And don't forget, help the helpers.
If in fact you prescribe to the thing that everybody's different, you don't know what's coming in the door. You don't necessarily have something in your therapeutic toolkit that can pull out and say, bam, right. Because everybody comes in different, right. But sometimes they come in like really ready to, and here it all comes. You can't just pull out something and say, this is the answer to that. You have to assess right now. You have to know if you need to, de-escalate. What do you have to do here? Every time.
And the key to that is being present. And your team knows that more than anybody else, to be present for that next person walking through and be fully present. So I'm hearing you for like it's the first person I'm hearing from today, even if you've talked to 15 people already, right? Because that is like, I do this 100 times a day, but that's their one time ever, maybe in their life that they're going to walk through that door. It's the old 𝐬𝐻𝐷imaggio thing. Like, why do you play so hard every day? He goes, because there's a kid that came to see me today and it's the only baseball game he's ever going to get to go to. And he deserves my best. Now, that's a nice line. I don't know if 𝐬𝐻𝐷imaggio really, who knows? But
let's say he did.
It's the same. I like to think that that's possible. It's the same thing, right? The Heathers, the Emilys, the Jennys, the Cathys, they need to, hang up that phone and up, and I am here and
that's
I'm present.
That's exactly what I've seen happen. That's how, you're just happy to hear from them, and what an honor, there are different agencies in this small town. There's agencies in Mount Vernon, in Akron, in Athens. We're growing so fast. Different states that we're going to over and above Ohio and New Hampshire. And there's a lot of agencies, right? But they chose this one.
Right.
And so it's our responsibility to make sure that they don't feel they made a mistake with that choice just by, I've heard them on the phone saying, honey, they said they could see me next week.
Amazing. My life has changed.
That's a great thing.
Because now I have hope.
Yeah.
I have hope. So,
not that we're great, but we're fortunate because we have the flex, and my team has the flexibility to say, I'm sorry, we only see people from that side of the town on this day. Yeah, whatever. We'll find, let's see what we can do, And our providers are great.
And we're great.
Well, the care they receive is really incredible. But like I've called or text a provider and say, hey, tomorrow I've got a guy, he's only available at this time. Yeah, go ahead, put him on. Yeah. And that's now 9 hours.
Right.
They've added another hour for this person.
Amazing.
And they always do it. I maybe a couple of times I've been told no, but it was for a real reason, not just I don't want to see anybody.
Of course. So to kind of wrap up, and I appreciate all this perspective. I know you've worked a full day. We're filming this at night. We're all voting. We're all hungry. So
you've worked a full day too, but but I'm old and I'm tired.
So I'll let you off the hook after this.
I should know better.
So with your perspective as in terms of like what's come in the past and how things have changed, and now your perspective on kind of what great service looks like on the front door in terms of addressing those barriers to care and building a team that can be ready for that. What's next? What do you think the future of access? What do you think the future of that behavioral health experience should look like, is going to look like? Where are we going with all of this? Or where would you like to go?
Well, personally, I have different opinions than a lot of people about it because I've done it for a long time and I've tried different models. I think you and I have had numerous discussions about this. I think if access is not managed and controlled in a particular way by a particular department, everything after that is chaos. You're just like, who's got that guy? What's doing this, right? I think that has to exist. I look for a time when we can actually do like a video call with our client. When they call in, we can just put them right on our duo or whatever on our phone system. which is coming and it's fantastic. And I think it has that ability, didn't she say?
I don't know. It looked like it could do everything.
Wouldn't that be great?
It'll order lunch. I don't know.
Wouldn't it be great if you were just like face to face with your client when they call in and they could see that they have your undivided attention? And, and that is another thing I will tell you. We very rarely put a client on hold. They've been trained that when they can't answer right away, they keep that call going. I don't know where it is. And their whole time they're looking for what they need. So, but I mean, I'd like that. I think that certainly the electronic model is going to take it all over, right? I don't think we should ever give up face-to-face. People just need it. They need it. And we need to see them face-to-face every now and then, right?
Yeah. I think what you're saying is this. Removing barriers to access is really just removing barriers to connection, right? If we could pop on video, I can see you, faces matter, we are connecting. Okay, the whole world's going digital, but we still have a front door. You can still walk in. It's different. Like we're still connecting, and we had kind of a dry run with that with COVID. If everybody's going to their pods and going to retreat into the matrix and, everything's going to be app-based, how do we retain that human touch and that human experience?
We still answered our phones till 9 o'clock every night. So, we got those calls, And some people didn't want to come, and that's fine. We'll just talk to you on the phone or get you on a doxy thing. What I am seeing, the future of it, at least I've seen a big trend in this. We get clients that associate with us. They do their intake, and the first time they come to schedule another appointment, they schedule their family, or they schedule a child with them, right? And so I think that the more that we're integrated with them, the more they integrate what's important to them.
That's nice.
And it's great. I mean, I'm really thankful that they feel that confident after this one visit, but. And I'm not making it up. It's truly happening a lot. Yeah. Will you see my husband and myself and our daughter? We had somebody in Claremont that wanted to bring in 6. Remember? Yeah. Can you put 6 in one office in a family? Absolutely.
And is there any greater endorsement or compliment than that?
Yeah,
like I'm getting a benefit.
But we didn't prod them. See, that's the thing.
Trust.
I think that they must have been thinking about that when they came in, right?
But they went first, and it's a trustworthy thing. Okay, I've sniffed it out. And it's
so that was the brave one that went first.
Yeah.
That's what I see. I think we need to do better every day. I think we just need to keep pushing. We need to keep trying hard and being creative and caring for each other in the leadership team and working together instead of pulling, two different ways. I think that as long as our core is strong, we'll continue to do things that, at least historically, are patient focused, patient first.
I know we're committed to keeping the first things first, and that's easy to say, but it takes communication and honesty and accountability. And I want to thank you for your creativity and flexibility. It's impossible to quantify when you talk about all those potential missed connections. And maybe we should start calling them connections instead of appointments.
I've been thinking about changing that or something.
I like that.
Yeah.
I like that. But those missed connections, it's what if you saved 100 connections, and of that, 50 lives got saved. You know what I mean?
That's fantastic. It's the old but tell me how not to feel bad about the one missed call.
Yeah. He knows how to do that. I don't know how to do that. No, I would recommend our You and Me and CBT, and I'd recommend our Dr. Boggs episode. I think they delve into those type of issues. But no, you've been a blessing to us, and you've been a blessing to a lot of your clients, and I want to thank you for your time. I think that gives a great perspective. And if anybody's listening to this that certainly has any anxiety, of course, they can call and connect, and you'll walk them through the process.
Yeah, they can actually call any of our offices. If they want to talk to me, tell them that you want to talk to me, and they'll get me somewhere, and I'll call you back. I mean, but anybody that you talk to that's in intake, I'm positive that they're going to treat you just the same way I would, have the same answers I have, so. Yeah,
I would say the sincerity, just the sincerity and genuineness of our care is exceptional. I mean, not perfect. Nobody's perfect, right? But it's like earnest effort to get it right and really try.
I think the thing that's so fantastic is we're well aware when we miss the mark, And so to me that, on top of the empathy that I look for in these people, I also look for those people that are also striving to improve every day. Yeah. And so when they say, that, and they bust themselves out all, Cathy, I did this, and stuff. And I'm like, okay, so stop feeling that way and call them back, kind of thing. So
cool. All right. Well, you did it. How was this? How was your
Exhausting.
podcast?
Tired. You probably tell on the way. I'm just like,
Well, let's
let's
get Cathy out of here before she hits the table. So thank you so much for coming by. I really do appreciate the time. For those of you watching or listening at home, again, ANEWBH.com. You've had a chance to meet Cathy now. She's the director of intake and client access. She leads the team that kind of opens that front door to care. So if you're in Ohio, you're in New Hampshire, anywhere, statewide, telehealth, in person, whatever, start with Cathy's team. Start with help now at AnewBH.com. And then if you need to proceed to ANEWBH, AnewBH.com. Help is always available. I haven't seen anybody go more than a day without a call back. And so I know that people are standing by willing to help. And we'll get you connected. Sometimes we're the answer, sometimes that we're not the answer. But you heard about that flexibility. You heard about that open-mindedness and creativity about if we're not the answer, people will find the answer for you. So that's our time for tonight. Again, if you haven't voted yet, too late, because this doesn't come out for like a week. So vote on the next time, and definitely make sure you're supporting people that support mental health and addiction care. They vote with their dollars. You can vote for them. Help the helpers. That's one way for you to help the helpers, is to reach out and support the people that will support this industry. We need the help, and we're helping people who need that help as well. So your support is always needed. So as always, thank you, producer Ian. Glad that you're here. He's barely awake. I'm going to shake him. He's going to edit this sucker. I'm sure I'll have it out by midnight, something like that. And then Duncan, you missed out. I had to go to a different coffee. Duncan, I've been angling for that Duncan sponsorship, and they did call and they said, don't use our cups anymore. So that's, so no, they didn't call, but they're going to. They're missing out. Hopefully they'll feel the pain from this episode. So again, Cathy, thank you for your time. Thank you, Ian. And until next time, take care of yourself and take care of each other. Thanks so much.